Welcome back to the deep dive. Today we're plunging into a topic that's, well, absolutely fundamental yet often presents with some critical nuance. Bradycardias.
That's right.
We're talking about those heart rhythms where the rate slows down below 60 beats per minute. Now, while that definition seems simple, the implications of a slow heart rate, they're anything but.
Not at all.
And for you, our medical students and junior emergency doctors right there on the front lines, understanding these nuances is just, well, critical.
Absolutely essential.
So our mission for this deep dive is to cut through the noise, really extract the most important clinical nuggets from the latest guidelines, from emergency medicine manuals, basically giving you a shortcut to being well-informed and confident when these rhythms walk through your ED doors.
A practical toolkit, essentially.
Exactly. So let's unpack this right away. When a patient presents heart rate less than 60, what's the very first question that should be firing in your mind?
Yeah, that's the perfect place to start. For any bradycardia, the critical first question you, the junior doctor, absolutely must ask is this patient hemodynamically compromised?
Right. Before anything else.
Forget the ECG for just a second. Are they in shock? Are they confused, suggesting maybe poor brain perfusion? Are they getting chest pain from myocardial ischemia? Or are they showing signs of acute heart failure? If the answer to any of those is yes, that's your immediate red flag. The urgency, how fast you need to act, it depends entirely on that hemodynamic stability.
Okay.
And what's really fascinating here, to understand why the heart might slow down, you need to quickly recall its electrical superhighway, right?
The conduction pathway.
Exactly. From the sinoatrial or SA node, that's the heart's natural pacemaker, down through the atrioventricular, the AV node, then the bundle of His, and finally the Purkinje fibers.
Okay.
Damage or dysfunction at any point along this, intricate pathway can lead to the slow rhythms you'll be seeing.
That makes perfect sense. Assess the patient first, always. Now, let's dive into probably the most common type you're likely to see. Sinus bradycardia. What's it look like on an ECG? And more importantly, how do you tell the difference between, say, a benign variation and a rhythm that needs your immediate attention?
Good question. On an ECG, sinus bradycardia is actually pretty straightforward. You've got a heart rate below 60 BPM.
Right.
And crucially, there's a P wave consistently before every single QRS complex. And the PR interval, that time from P to QRS, it's constant.
P for every QRS, constant PR.
Got it. Exactly. Now, here's a really crucial point for you. It can be a perfectly normal physiological variant.
Like in athletes.
Precisely. Think of that healthy young marathon runner or even an older patient who's on an appropriate dose of a beta blocker for hypertension. These patients, they're typically asymptomatic.
Right.
And for them, this slow rate is normal. It only becomes pathological and therefore warrants your intervention when it's causing symptoms. Symptoms of decreased cardiac output.
Like dizziness, lightheadedness.
Yeah. Dizziness, lightheadedness, maybe profound fatigue, pre-syncope. So the key takeaway for you here is sinus bradycardia plus asymptomatic usually equals benign, but sinus bradycardia plus symptoms, that equals a problem you need to address.
So it really is about the patient's response, not just the number on the monitor. Which brings us to where it gets, well, really interesting, because there are specific causes of sinus bradycardia that have unique twists in management. Things you, as an emergency doctor, absolutely need to have on your radar. What are some of those critical outliers?
Oh, it truly does get interesting there. Beyond just the standard is the patient okay approach, we need to be super aware of a few specific causes that really change how you manage things. Take hypothermia, for instance.
Okay.
As the core body temperature drops, the heart rate naturally slows down, and you might see those characteristic J waves or Osborne waves on the ECG.
Or the little bump after the QRS.
That's the one. The critical insight here for you is that you don't aggressively warm these patients externally until you're prepared for potential arrhythmias, like VF. Focus on internal rewarming and know that these rhythms often correct themselves as the temperature comes back up.
So core warming, gentle approach. Okay.
What else? Then you've got drug toxicities, big category. For beta blocker overdose, atropine, which is usually your first go-to drug, often isn't very effective.
Why is that?
Because the beta receptors are already blocked, saturated by the overdose. So atropine can't really work its usual magic. Here, you need to think differently. Consider high-dose intravenous glucagon.
Glucagon. Interesting.
Yeah, it bypasses the beta receptor and increases cyclic AMP directly in the heart cells. Or you might need adrenaline or isoprenaline infusions.
Got it. Then calcium channel blockers.
For calcium channel blocker overdose, the key insight is to think of calcium itself. Intravenous calcium directly counteracts the block at the cellular level. It's not just supportive care, it's a specific antidote action.
So calcium first.
Calcium first, definitely. Then consider your inotropes like adrenaline if needed. Digoxin toxicity is another classic. It can cause a whole mess of arrhythmias, including bradycardia, and its toxicity gets much, much worse if the patient has low potassium hypokalemia.
Check the potassium.
Absolutely. Correcting electrolytes is crucial, and in severe cases, dig-specific Fab antibody fragments, digibine, that's your antidote.
Okay, what about toxins?
Right, like organophosphates, often from pesticide exposure. These cause a massive cholinergic crisis, just flooding the system with acetylcholine.
Parasympathetic overdrive.
Huge overdrive. Your treatment here is atropine, but not the usual dose. Massive titrated doses of atropine, often milligrams at a time, until you see signs of atropinization, like a dry mouth or dilated pupils. You're fighting that profound overdrive.
Wow, okay. And one more really critical one.
Yes, the really ominous sign in head injuries. Bradycardia combined with hypertension. That's the Cushing's response, or Cushing's triad if you include irregular respirations. It's a critical red flag.
What does it mean?
It means significantly raised intracranial pressure, likely due to brainstem compression. That's an immediate neurosurgical emergency. Get help fast.
Okay, that's a fantastic rundown of those specific tricky scenarios with sinus brady. But what if the problem isn't just a slow pace set by the SA node? What if it's deeper? What happens when the SA node itself, the primary pacemaker, starts to really falter or even completely fail?
Right.
That takes us into things like sinus arrest and that broader, more complex diagnosis, success in sinus syndrome. These signal primary cardiac issues that really demand your attention.
Exactly. So sinus arrest. On the ECG, this looks like pauses, just
Yeah.
flat lines where you'd expect a P wave and QRS. Often we define it as pauses of 3 seconds or more, and they can be intermittent.
So it comes and goes.
It can, yeah. And surprisingly, it can sometimes be asymptomatic. Or it might cause pre-syncopal symptoms like feeling lightheaded, maybe dizzy, or even full syncope fainting.
What causes that?
Could be intrinsic SA node disease. The pacemaker itself is just wearing out or diseased. Or it could be external factors like carotid sinus hypersensitivity. You might see that in some vasovagal episodes or even micturition syncope, basically an over-the-top vagal response.
Okay. How do you manage it?
Well, management primarily involves stopping any drugs that might be making it worse, like beta blockers or calcium channel blockers if they're not essential. Rarely, if it's severe and causing lots of symptoms, a permanent pacemaker might eventually be needed.
And how does that fit into sick sinus syndrome?
Right, so sick sinus syndrome is kind of the umbrella term. It's a broader and often more complex diagnosis. It's not just one specific rhythm. It's really a spectrum of SA node dysfunction.
So it can look like different things.
Exactly. It can manifest as chronic persistent sinus bradycardia or recurrent sinus pauses like we just discussed, or sinus arrest, or, and this is a key one, a tachycardia bradycardia syndrome.
Natchy, Brady. What's that?
That's where patients swing between episodes of really fast rhythms, often atrial fibrillation or flutter, and then suddenly switch into periods of profound bradycardia or asystole when the fast rhythm stops.
Wow, that sounds difficult to manage.
It is. The underlying cause, the pathophysiology, often involves things like underlying cardiac ischemia or dilated cardiomyopathy, or sometimes just age-related fibrosis of the SA node. Essentially, the wiring just degrades over time.
And the prognosis.
Unfortunately, it often carries a poor prognosis because it usually reflects significant underlying heart disease. Acute management in the ED, it's supportive care oxygen, maybe judicious 5E fluids, treat any underlying ischemia if you can identify it. Atropine. Its effect is variable.
Why is that?
Because the problem isn't always just excess vagal tone. The node itself might be diseased, so atropine might not speed it up much. Ultimately, these patients often need temporary pacing initially, and then permanent transvenous pacing to maintain an adequate heart rate. Sometimes they need pacing plus drugs to prevent the tachycardias too.
So we've seen how the SA node, the heart's main driver, can become dysfunctional or even quit. But what if that primary pacemaker goes completely offline? Does the heart just stop?
Thankfully, no. Most of the time, anyway. The heart has these incredible backup systems. We call them escape rhythms.
Backup generators.
Exactly like that. They're truly the heart's last-ditch effort to keep blood pumping when the main system fails. Let's dig into the two main types you'll see. Junctional and idioventricular rhythms. Recognizing these is vital when the chips are down.
Okay, so first up, junctional rhythms. What's happening there?
Right. So when the SA node fails, The next potential pacemaker down the line is the AV node, or the tissue right around it, the junction. So a junctional bradycardia originates there. It acts as a backup.
And what does it look like?
It's typically a regular rhythm with a rate usually between 40 and 60 beats per minute. And importantly for you, it usually has a narrow QRS complex.
Narrow QRS. Why is that important?
Because that narrow QRS tells you the electrical impulse, even though it started lower down, is still being conducted efficiently through the normal His-Purkinje system down into the ventricles.
Ah, so the downstream wiring is okay.
Generally, yes, and that distinction is crucial for prognosis. It usually indicates a less severe conduction problem compared to a rhythm with a broad QRS. Junctional rhythms aren't usually physiological. They're almost always a sign of some pathology, often drugs or ischemia affecting the SA node.
How do you treat it?
Management involves finding and correcting the cause if possible. For symptomatic patients, your first-line drug is usually intravenous atropine.
Does atropine work better here than in sick sinus?
It often does because the AV node is still somewhat responsive to vagal tone modulation. Prognosis is generally decent, but if it persists and causes symptoms, these patients might eventually need a permanent pacemaker.
Okay, so that's the junctional escape. What about the other one? Idioventricular rhythm. You said that was the last-ditch effort.
It absolutely is. This is a ventricular escape rhythm. It means the impulses are starting way down in the ventricles themselves.
Why would that happen?
Because all the higher pacemakers, both the SA node and the AV node, have completely failed or are blocked. There's no signal getting through from above.
Wow.
So the ventricles themselves try to take over. This results in a broad, complex QRS on the ECG.
Broad QRS this time.
Yes, because the impulse isn't using the fastest Purkinje highway. It's spreading slowly, cell to cell, through the ventricular muscle, and the rate is very slow. Typically 40-50 BPM if it starts high up in the septum, but maybe even slower, like 30-40 BPM if it originates from lower down in the ventricle wall.
That sounds incredibly unstable.
It is. This is a truly ominous rhythm. It signals widespread failure of the heart's electrical system. It almost always means profound hemodynamic compromise. It's the heart barely keeping itself going.
It really does sound like the heart's final, desperate attempt. And to really get a handle on these escape rhythms, especially the idioventricular one, we need to understand why the SA or AV nodes might be failing in the first place.
Exactly.
Which brings us squarely to the different degrees of atrioventricular or AV block. This is where that electrical signal hits some serious roadblocks on its way down. Can you walk us through those? Because this feels like where things can go from concerning to critical very, very quickly.
Absolutely. Think of AV blocks like different levels of traffic jams on that electrical highway between the atria and the ventricles. Some are just slow traffic, others are complete standstills.
Okay, let's start mild. First degree AV block.
Right. This is the mildest form. It's really more of a consistent delay than a true block. On the ECG, what you'll see is a constant prolongation of the PR interval. It's always longer than normal, over 200 milliseconds, or one big square on the ECG paper.
But every beat gets through.
Every single one. Every P wave still conducts to a QRS complex. It's most commonly just a normal variant, often seen in athletic individuals, totally asymptomatic, and generally doesn't need any treatment.
Well, you keep an eye on it.
You do, especially if it appears newly in the context of, say, an acute coronary syndrome. It might signal some early fibrosis or ischemia affecting the AV node, but the key here is no dropped beats, just consistently delayed ones.
Okay. Moving up in severity, second degree AV block.
Now things get more complicated because here some atrial impulses do fail to conduct normally down to the ventricles. There are dropped beats, and there are two main types you need to know.
Mobitzian and Mobitz 2.
Exactly. First, Mobitz type I, also known as Wenkebach, think Wenkebach.
Boink.
Yeah, because the PR interval progressively lengthens with each successive beat. It gets longer, 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 and then wink. A P wave suddenly isn't conducted at all, and you get a dropped QRS complex. The pattern then typically resets and starts again.
Okay, progressively longer PR than a dropped beat.
That's Wenkebach. This is often seen after inferior myocardial infarctions, affecting the AV node itself. It's usually more benign, often asymptomatic, and frequently resolves on its own without urgent intervention. Observation is often enough.
Okay, that sounds manageable. What about Mobitz type 2?
This is the one where you should be much more concerned. With Mobitz type 2, the PR interval stays constant for the conducted beats. It might be normal length, it might be prolonged, but it's constant. Then suddenly, without any warning lengthening, a P wave fails to conduct the ventricles and you get a dropped QRS.
So unexpected dropped beats with a constant PR.
Precisely. This is less common than type I, almost always symptomatic, and it's of much greater concern. Why? Because it usually signifies a problem below the AV node, often in the His-Purkinje system, maybe due to septal involvement in an MI. And critically, it has a high risk of progressing suddenly to complete heart block.
Okay, that sounds serious.
It is. For any junior doctor, seeing Mobitz type 2 on an ECG, that should be a hard-mouth moment. Your immediate mental checklist should be anticipate progression, prepare for pacing.
Right. Which leads us to the most severe third-degree AV block or complete heart block.
This is the ultimate failure, the complete traffic shutdown. There is absolute dissociation between the atria and the ventricles. The P waves are marching along at their own atrial rate, and the QRS complexes are marching along at their own, much slower, ventricular rate. No P waves conduct to the ventricles whatsoever.
Complete separation.
Complete separation. This is when you'll typically see that broad, complex ventricular escape rhythm, our idioventricular rhythm we talked about taking over, just to keep the patient alive.
And the rate is very slow again.
Usually very slow, often in the 30s or 40s. Patients almost always present with profound symptoms. Lethargy, pre-syncope, full syncope. It signifies significant underlying disease, fibrosis, ischemia, and almost always requires a permanent pacemaker.
And in the context of an MI,
Critically complete heart block, especially in the setting of an anterior myocardial infarction, is a very poor prognostic sign. It usually indicates extensive, often irreversible, damage to the septum and the conduction system.
that progression really hammers home the increasing urgency. So, okay, let's bring it together. You've recognized a bradycardia. You've rapidly assessed the patient's stability. Are they compromised or not? You've hopefully identified the type of block or rhythm. What are your go-to general management strategies in the emergency setting, especially for those symptomatic, unstable cases?
Absolutely. Number one rule, and I can't stress this enough for you, the junior doctor in the thick of it in the ED. Treat the patient, not just the ECG strip.
Patient first.
Always. If that patient is hemodynamically unstable because of their bradycardia, their crashing, confused chest pain, that's your cue for immediate aggressive action.
Okay, what's first?
Your first-line drug for most symptomatic bradycardias is atropine. Give 0.5 milligrams intravenously. You can repeat that every 3 to 5 minutes up to a total dose of 3 milligrams.
How does it work again?
It works by blocking the vagus nerve's action on the heart. It essentially takes the brakes off, letting the heart rate increase. That's why it's often very effective when high vagal tone is the culprit, like in sometimes a syncope or inferior MI.
But you mentioned it's not always effective.
Right. You need to understand why. It's less effective if the problem is, say, a fibrosed AV node in high-degree block, because the issue isn't excess vagal tone anymore. The wiring itself is physically damaged. It's also generally less effective in most drug toxicities, with the notable exception of organophosphates, where you use huge doses.
Okay. And any pitfalls with atropine?
Yeah. A crucial practical tip. Doses below 0.5 milligrams might paradoxically worsen the bradycardia. So don't underdose it initially. Give the full 0.5 milligram.
Got it. What if atropine doesn't work or the patient is really hypotensive?
If atropine isn't cutting it, or if you have persistent hypotension despite an adequate heart rate, you move to inotropes, or pacing. For inotropes, adrenaline given as an infusion, usually starting around 2 to 10 micrograms per minute, is often preferred.
Why adrenaline?
It's potent, has both chronotropic rate and inotropic contractility effects, and importantly, it has a rapid onset and offset, making it easy to titrate. Isoprenaline is another option, mostly increasing heart rate, typically started at 5 micrograms per minute. But remember, these are generally temporizing measures.
Buying time for pacing.
Exactly, buying time to get definitive pacing sorted. And then there's pacing itself. Initial pacing in the EED is usually non-invasive.
Okay, what are the options there?
Well, for true emergencies, like ventricular standstill where you still see P waves, but no QRS known as PEA, with P waves, you can try percussion pacing.
Hitting the chest?
Yeah, delivering repeated firm thumps to the precordium, just lateral to the lower left sternal edge, while watching the monitor and feeling for a pulse. If it doesn't work quickly to produce a regular pulse, you move straight to CPR. It's really just an immediate bridge while someone else is getting the transcutaneous pacer ready.
Okay, so transcutaneous pacing, TCP, how does that work?
This can be set up quickly and easily. You apply the pads, usually one on the right upper chest pectoral and the other near the apex, or sometimes an anterior-posterior placement. Set the device to demand mode, typically aiming for a rate of 60 to 90 BPM. Then you gradually increase the current, the output in milliamperes,
Until
until you achieve two things. First, electrical capture. That means seeing a QRS complex immediately following each pacing spike on the monitor. And second, crucially, mechanical capture. You need to feel a corresponding palpable pulse with each captured beat. Electrical capture without mechanical capture isn't perfusing the patient.
Right, need the pulse. Anything else about TCP?
Yes, warn the conscious patient. It's uncomfortable, sometimes very painful because it stimulates the chest wall muscles. So have analgesia, maybe sedation ready. It's a temporarily life-saving measure, but it's not pleasant.
Okay. And longer-term temporary pacing.
That would usually be temporary transvenous pacing. This involves threading a pacing wire through a vein into the right ventricle. While it's less common to initiate this in the absolute chaos of an acute arrest, it's often the next step after non-invasive pacing has stabilized the patient, usually performed in a more controlled setting like the ICU or cath lab with expert help.
We've certainly covered a lot in this deep dive into bradycardias. It feels like we've gone from the pretty common sinus bradycardia right through to the complexities of sick sinus syndrome, those critical AV blocks, and the absolutely vital escape rhythms.
It's a big topic.
It really is. But I think the key takeaway for you, the junior doctor listening, is that systematic approach we talked about. First, always assess for hemodynamic compromise. Is the patient stable or unstable?
Critical first step.
Then really take a moment to understand what you're seeing on the ECG. What's the underlying rhythm or block?
Yep.
Know your go-to pharmacological options like atropine and adrenaline, but also understand why they work and when they might not.
And their limitations, yes.
And finally, be ready. Be prepared. Know how to pace the patient if needed, starting with that transcutaneous pacing in the ED.
That sums it up well. Assess, interpret, treat appropriately, and escalate to pacing when necessary.
So as you step into your next shift and you inevitably encounter these slow rhythms, here's something maybe a bit more philosophical to consider, a provocative thought perhaps. In our world of increasingly complex medical interventions, how do we balance that imperative we feel to fix a rhythm, to get that number on the monitor back into the normal range? How do we balance that with the overarching goal of supporting the patient's overall well-being and their functional status? When is a slow heart rate truly a problem that needs chasing with every tool we have? And when might it be, perhaps, just a sign of a body that's naturally slowing down as part of its course, requiring a different kind of care, maybe less aggressive?
That's a profound question. Where does aggressive intervention meet compassionate care for the whole person?
Exactly. Something to definitely mull over as you continue to learn and grow in your practice.